Module C, this is selected neurological alterations to include TIA, CVA. Beginning with transient ischemic attacks. In IGGY, on your 8th edition, it is chapter 45. On your 7th edition, it is chapter 47. Transient ischemic attacks, stroke, or cardiovascular accidents. A temporary neurologic deficit that is caused by a brief interruption of cerebral blood flow. This possibly is due to blood vessels becoming occluded by vasospasms, fragments of plaque, or blood clots. It also may be the result of a systemic arterial hypertension. Now, the difference in a transient ischemic attack, or a TIA, and a reversible ischemic neurologic deficit, or RIND, is basically the length of time that the patient experienced symptoms. A TIA lasts for a few minutes to a few hours, but typically less than 24 hours. Usually a TIA will last between 30 minutes and 60 minutes. So oftentimes the patient presents to the emergency department asymptomatic and appears stabilized. Chart 45.1 in your 8th edition and 47.1 in your 7th edition. RIND symptoms are going to last for more than 24 hours, but less than a week. Now, both your TIA and your RIND can cause damage to the brain tissue with repeated episodes. This damage can be seen on an MRI or a CAT scan. These actual processes, TIA and RIND, don't sound so significant in and of themselves, but what is significant is that if a patient is having these or multiple episodes of these, damage is being done and they are at an increased risk for having a stroke. Signs and symptoms are momentary confusion. The visual deficit is blurred vision, diplopia, ptosis, blindness in one eye, or tunnel vision. Motor deficits include weakness in the arm, hand, or leg, gait disturbances such as being ataxic. Sensory deficits are numbness or tingling in the arm, hand, or face on one side of the body, vertigo, and tinnitus. Speech deficits are expressed such as aphasia, dysarthria, dysphagia, drooping on one side of the mouth. When a client presents to the emergency department, as I said, they are typically going to appear stabilized. A medical diagnosis is going to be formed with a complete neurological assessment, routine labs such as a complete metabolic profile, electrocardiogram, CAT scan without contrast. For these patients presenting normally looking stabilized at this point, hospitalization is going to occur for most patients that are over the age of 65 and or those with diabetes, or patients whose symptoms have lasted longer than 10 minutes, or that present with a motor or speech deficit. These are the ones that are usually going to be admitted regardless. I'm sorry, we're going to back up. Your medical treatment may include a carotid ultrasound, a transesophageal echocardiography. Now, this is going to be done if the patient has a history of atrial fibrillation, prostatic heart valve, or a history of rheumatic heart disease. Surgery may be done if plaque is formed within the carotid arteries. A transluminal angioplasty is a procedure done to enlarge a narrowed arterial lumen by peripherally introducing a balloon-tipped catheter, followed by dilating the balloon and dilating the lumen of the artery, and then withdrawing the catheter as the tip is inflated. After a TIA occurs, several medicines may be prescribed. These medicines are usually prescribed to prevent blood clots because it is the clots that can cause TIAs and then lead to strokes. The two major classifications of medications that prevent your clottings are antiplatelet medicines and anticoagulant medications. In addition to these, cholesterol-lowering and blood pressure-lowering medications may also be used to prevent TIAs and strokes. At the time of discharge, your client is usually going to be placed on an anticoagulant therapy such as aspirin or Plavix or Coumadin or heparin to decrease platelet clumping unless this is contraindicated. So as the nurse, you will also need to complete extensive discharge instructions on bleeding precautions, as well as to follow up with all scheduled blood work and appointments with their cardiologist. A stroke, which is sometimes referred to as a brain attack, is a medical emergency. It is caused by any disruption in the normal blood supply to the brain. A stroke is a medical emergency. It does strike suddenly and requires immediate treatment to prevent neurological deficits and permanent disabilities. It is an abrupt impairment of brain functioning that results in a set of neurologic signs and symptoms. These are caused by the impaired blood flow to the brain and last more than 24 hours. Stroke is the third leading cause of death in the United States, with approximately more than 140,000 people dying each year from a stroke in the United States. 75% of all strokes occur in people over the age of 65. The risk of having a stroke more than doubles with each decade of life after the age of 55. Strokes can and do occur at any age, leaving 25% of strokes occurring in people under the age of 65. The brain is not able to store up oxygen or glucose, and it must receive a constant flow of blood to provide these in order for normal functioning to occur. If the blood flow is interrupted in any part of the brain for more than a couple of minutes, the cerebral tissue dies. The death of this tissue is called an infarction. Blood flow and metabolism are then affected after a stroke around this infarction site, as well as in the opposite side of the hemisphere of the non-affected side. This is referred to as contralateral. It may be the result of brain swelling, which causes the symptoms of increased intracranial pressure and is life-threatening all by itself. But at the very least, this all will result in varying degrees of disability. When a client presents in the emergency department with any stroke-like symptoms, an immediate general assessment by a stroke team and/or the ER physician evaluation needs to take place within 10 minutes of arrival. If the patient is a hospitalized client and has a stroke, the evaluation is still needed to take place within 10 minutes. Give priority assessments to your ABCs. Nurses will also be performing a complete neurological assessment upon presenting to the emergency department. As I said, a non-contrast CT scan needs to be ordered. Neurological assessment by the stroke team and the CT needs to be performed within 25 minutes of arrival. And at that time, an interpretation of the CAT scan will need to take place within 45 minutes of arrival. The initiation of TPA, which is tissue plasminogen activator, will be given in appropriate patients within 1 hour of arrival at the hospital, and up to 3 hours is optimal from the onset of symptoms. This window has been extended to include up to 4.5 hours after the arrival or onset of symptoms. TPA therapy is also referred to as thrombolytic therapy, and it can be used to treat patients who are having an ischemic stroke because it dissolves blood clots. TPA and RTPA are basically the same, except for the RTPA is the recumbent tissue plasminogen activator, or meaning that it's lab created. The goal for stroke patients is from the emergency door, admitted to the floor, takes no more than 3 hours total.